Did you guys get the hepatobiliary one? Or just not the respiratory one? Okay. Did you guys have any questions with the hepatobiliary one? No? Pretty straightforward. Can you hear me? Somebody's
That works. Everyone? I think I sent y'all the link to mine, so if you wanna save it as a copy for yourself.
Mm-hmm.
Because if you get on this one and edit it, it'll, change this one, so just save it as a copy. For download.
Oh, yeah.
I think
A lot of people have got it. Some of you have it, but I can see you.
I have it. Yeah.
So just
Just share
forward
it.
to your classmates. Okay. So I'm gonna get started so we can go. This is Bubbles, 2-year-old female Boston, who presented for a physical exam. The owner wants to breed it. However, this dog has that open mouth, heavy breathing. On physical exam, you can see this is what this dog looks like, a typical startled look. Does anyone know what kind of noise I'm talking about and what the name of it is?
Sure.
Which one?
Starter.
Yes, starter. Okay. Do we know what it's secondary to or why it's doing that? That's one of them. It's a complex. So, So the main thing I'm looking for is stenotic. Yes, stenotic mares. So that would be your most likely differential, especially for this breed. I have that face. Okay. And then we already know the term. So here we break down ways for you to figure out how to tell the difference. So with starter, it's kind of a snort, and then with strider, it's kind of a whistle. It's the best way I can explain it. It'll be hard to understand what you're saying until you actually hear it. So I don't know when you guys start clinics, but make sure that when you do, if you see one of those breeds, to make sure and take a listen to them. It's very distinct. And then here's a video which may or may not help you out. So do we know the other three things in that complex? Hypoplastic trachea, elongated soft palate, something about saccules. Okay, yes, elongated, everted laryngeosaccules. So the only one out of these things that's actually acquired is the saccules. Everything else they're born with or have inherited. What would you tell the owners about if he's interested in breeding? What would you suggest?
Don't do it.
Absolutely not. So as far as treatment, it's surgery. Have you guys had Dr. Lynn yet?
Yeah.
Today, maybe? Okay, great. Then we don't have to talk about surgery because she gives you lots of pictures. But you'll definitely want to do a wedge resection with those mirrors. And depending on how bad it is, you might need to do some type of amputation or more involved surgery. It's kind of scary looking. Any questions about the brachycephalic syndrome? Okay, this is Jack. He's a toy poodle with this very nasty looking, wet, abscessy looking face with mucoperineal discharge. He's not eating, it's probably painful, and there's discharge below his eye. So what's the first thing you think of? Fistula or an abscess, yes. So your problems, nasal discharge, draining tract, not eating. Those are your top three things that you're going to see with these things. So the first thing you're going to do is look where? In the mouth. So this is what we're looking at. Pretty distinct when you see them. And usually a classical case, no extra or anything hard about it. You just see the eyes. Make sure when you see any discharge with these dogs, immediately look in their mouth, especially if they're not eating. So this is a fistula. One of the most common places that you'll see this is that upper fourth premolar. Remember that, upper fourth premolar, especially if the discharge is up high on their face and right below the eye, because that's exactly where that tooth is when you open their mouth. It can be due to a number of things. Most common is actually the tooth root abscess. Periodontal disease can cause this or become a sequela to this, as well as other abscesses in the mouth. So how would you diagnose it? Other than looking at the mouth, what's another way? If it's not that big hole, what's another way you could diagnose an warning?
Radiographs?
Yes, radiographs. A lot of the times you'll want to do these exams under anesthesia. Obviously, we don't want to be bit, or a lot of times they won't open their mouth for you. So if you can get the owner to do that, that would be great. So it says it in the picture, but again, remember that tooth, upper fourth premolar. How would you treat it?
Surgery? Surgery?
Pull what? Pull the tooth. Okay. Any drugs? Lots of drugs. Main drug?
Clindamycin?
Clindamycin. Yes, you definitely want to throw some antibiotics at this, especially if you have an infected tooth. Clindamycin is definitely one that we use mostly for periodontal disease or tooth root abscesses, or even I've seen doctors use it for extraction just to be sure. And yes, surgical closure with the flap. You don't want to leave that open so that when they're eating, things can get in there, and then they'll be back in the next week with a whole other problem, an abscess. So make sure we close that. Okay, questions about fistulas? Yes.
The flat,
Yes.
closure and everything, that's not something that Dr. Martin looks at, it's like procedures.
No, but Dr. Lund might ask you how to close, or what if this dog has a hole that's too big in their mouth, what would you do?
And what tissue are you using for that?
So when you get to dental lab, I have no idea what that is. I think it's at the end of the semester. Yeah. You'll see. So eventually you're just gonna cut their gum with a scalpel, but they're underneath. And that way you sometimes like move it over. It's really hard to explain, but you actually do all of this in this lab. You just take a piece of it and move it. It's like a graft.
Oh.
Yeah. Disgusting. So this is Leo, 1 year old. Are there any more questions? Okay. So this is Leo, 1 year old, male neutered cat with this nasty upper respiratory infection, sneezing, ocular discharge. They just adopted. So what are some top differentials? Herpes, definitely, and one more.
You want upper
Police.
respiratory?
Or yes, so it's a part of a complex, and then there's bacteria as well as the viruses. The top two that we're thinking is herpes, definitely herpes. These cats. There is upper respiratory complex. Do you know the other things?
Mycoplasma,
Mycoplasma,
chlamydia,
chlamydia,
possibly Bordetella.
possibly Bordetella. Exactly. So herpes, Callice, chlamydia, Mycoplasma, Bordetella. Bordetella more so with dogs, if they live with dogs. There's a distinct thing in herpes that you'll see. You know what that is? Dendritic ulcers. And then with Callice, not as distinct, and not all cats get it, but there is something that they also get with Callice. Do you know what that is? They do get stomatitis or ulcerations. They also get lameness. So if they come in with kind of like this limping thing, and they have upper respiratory in addition to the lameness, and they're a young cat, I would check those titers out for Callice as well. So we'll leave that. So just keep going. Everybody upper respiratory has ocular and nasal discharge. That's not a real clinical sign to help you. They all have it. But yes, the herpes has the ulcers, more so dendritic ulcers, and you use the fluorescein. I don't know if they mentioned types of stain. No? Rose bingo usually for herpes. Yeah, if Newkirk hasn't, then they will, but Rosenville definitely gets those dendritic ulcers. Cyclofluorescein. And Khaleesi, again, ocular nasal discharge, that's not helpful. Anorexia, maybe all cats stop eating when they don't feel good, but the oral ulcers is what we're going to look for with Khaleesi. The arches, the palatine arches, don't really know how to explain it, but when you open their mouth and you see the, you know what I'm talking about? That's usually, no, the arches, the palatine arches. That's actually one of the most common places that you'll see the ulcers. I mean, they're all over the mouth, but usually I would look there first. And then the larynx. So predisposing factors, again, especially if they're unvaccinated, if they're young, this is a common thing. Herpes and Khaleesi both see in shelter type environment. When you're on ambulatory, you'll see lots of nasty, sneezy kitties. And keep in mind that herpes is lifelong. So you can treat the symptoms, but you cannot get rid of it. That's in all animals. So the way the bacteria works, because a lot of them are, especially with mycoplasma, it's normally there. So if you have a virus that's causing your immune suppression, the bacteria usually come in and join the party. So especially with mycoplasma, it's already there. It's not causing any problems. But if you have a cat whose immune system is compromised, you can definitely expect to see some bacterial components too. So when you treat anything with the virus, especially with the upper respiratory, make sure you get some antibiotics on board to get rid of those secondary bacterial infections as well. Okay, so how would you diagnose feline viral rhinitis? Which one?
Alexa.
Okay, let's go standard. ELISA doesn't always, there's always some cross reactivity. PCR, okay, you can also do IFA. There's certain inclusion bodies that you see with herpes. Anybody know which one that is? Okay, what about chlamydia? Intracytoplasmic, so definitely do a swab to get these types of samples, but that thing in red, intracytoplasmic inclusion body with chlamydia. Yes.
So, for the purpose, I guess, of her test, how would you be able to differentiate if it was just Khaleesi or just herpes or the complex itself? Like, what was the answer point you need?
Okay. So remember when I was saying nasal and ocular discharge doesn't mean anything, but dendritic ulcers and lameness and stomatitis do.
Okay.
Herpes, you'll more so see the ocular issues as opposed to ulcers. I know that they say, you know, they can get ulcers with herpes too, but if you see ulcers, the first thing I'm thinking is Khaleesi, always. Lameness, it's weird. Remember those weird random clinical signs that don't really make any sense. I mean, it has a reason, but the lameness, that's immediately Khaleesi. If it's a 1-year-old or a shelter cat, all of those are pointing at those viruses. The thing about the bacteria is not usually there. It's only there if you have immunosuppression, usually. And she doesn't give you like these wild outlandish scenarios. It's usually pointing you to one direction.
Okay.
So treatment options, again, supportive. You can't get rid of the virus with an antibiotic. It's not a quick fix. But you do want to make sure you're getting that discharge out their eyes, clearing your nose. You don't want them to swallow any of that because then we have aspiration pneumonia and bronchopneumonia. So it's all supportive care. If they can't breathe, oxygen, bronchodilators, antibiotics for those secondary infections. The key things to remember with drugs, because she loves to ask about drugs, azithromycin cannot be in sunlight. It deactivates the actual ingredients. Doxycycline, don't give that in cats unless you absolutely have to. Why? It's right there. Yes, esophageal strictures. If you do absolutely have to use it, because there are some type of diseases where you will, make sure you follow it up with lots and lots and lots and lots of water. Okay. There is some talk about antivirals for herpes. Depending on who you ask, they say it works. It doesn't. It can just be a add-on. It's just an additive. It's not your main thing. Your main thing is to prevent secondary infection, keeping the eyes and nose clear, help them breathe if they need it, and if they stop eating appetite stimulant, so we don't get fatty liver. So what are the bacteria that you can see as a result of a virus? There's two, chlamydia and mycoplasma, yes. And we already talked about the intracytoplasmic inclusion bodies. Can you treat it? Yeah, sometimes it depends on your patient. Most of the time, you want to treat your patients if they're super clinical. Don't throw a whole bunch of stuff at them if they're not. You build up resistance. So usually it can go away, but I mean, if this cat can't breathe and it's got stuff pouring out of his eyes and nose, you can throw some antibiotics at it. But mainly we're worried about those viruses. Adverse drug effects of tetracycline and doxy. Tetracycline in young animals.
Cartilage.
Teeth staining, yes. What about the doxy that I just mentioned? Strictures, okay. Which bacteria, because it's a bacteria, is not pathologic? It's a normal inhabitant mycoplasma. Okay. All right. Any questions about your feline upper respiratory complex and its constituents? Okay. This is Bucky, 2-year-old Valentine GSD, German Shepherd. He's got this nasty nasal discharge that actually starts to bleed after a while. Discharge was initially unilateral, but now it's on both sides. And then also his nose has become a little pale. So what are some differentials? Aspergillus, okay. It's a fungus. What else? How old is it? 2? There's a few, but the one I want is Aspergillus. What was pointing you to Aspergillus? Yes. Okay, good. So here's some radiographs. Whoops. That doesn't move very well. Did she put radiographs in the test?
Yeah.
She for upper respiratory. No. I don't think so. But if you do see this clear missing section, that would be it. CT, she doesn't ask about CTs because we don't actually learn that here. So I wouldn't worry too much about that at the moment. So we get to the end of radiology. Yes?
The right picture where you think the antibodies,
The CT?
mm-hmm.
Mm-hmm.
You mentioned the clear part. Is it not the opacity is what's wrong?
Yes, the opacity. So if they call it a loss of detail or a loss of turn. So what is happening is that fungus is eating your cartilage and your bone away inside the
So that's normal, and then the loss, the lucency part.
lucency.
That's
Lucency is abnormal because you do have some structures in there. You got bone in there, you've got cartilage in there. When the fungus comes in, it starts eating that bone away, then you just have this gaping hole in your nasal area. What's a good way to diagnose this other than radiographs and CT? Another way.
Serum with the antigen.
Serum, yes. What else? Biopsy, yes. But how do you get the biopsy?
This one?
Okay, yes, bronchoscopy. Exactly. So it's that. It actually is this yellow. I've seen it as tan, but it's a mass. It's not pink like the rest of the nasal epithelium. And yes, biopsy is definitely the best way. You can do a culture, but when we're talking about gold standards, which is what Dr. Martin usually wants, which is what Natalie wants, gold standard is biopsy. So how would you treat this doggy?
Is it horrible?
Antifungals, yes. Which one?
Ketoconazole?
Clotrimazole, how do you get that?
Oh. I was thinking ketoconazole.
You can give ketoconazole, but for this specific fungus, we're looking for clotrimazole. And it's actually like an infusion. Yeah.
So you have to do it surgically.
Yeah, they have to be under anesthesia because they're hurt.
Justin, is this a procedure that they plug everything, the mirrors, the palate, everything?
Yeah. All right. The main thing about that is we just don't want to cause aspiration pneumonia treating this dog for one thing. We want to cause it to have, pneumonia when you're treating it for an upper respiratory problem. So you make sure you close off your airways. And make sure you give it slowly. Yes, clotrimazole is your treatment of choice. You can also give ketoconazole or itraconazole. Okay. There are other options. I actually haven't seen anyone else talk about it. They're there for your knowledge. But clotrimazole, and if the owner is like, I don't really think I want you to do that, ketoconazole or Istra orally. Oral, ketoconazole. Okay, side effects of ketoconazole and yes. Yes, they need to be under general. Yeah. It's, the risk factor about that is if they're awake while you're infusing their nose, they're not going to just let you keep their airways closed or, all of that if you breathe. So they have to be awake. They have to be asleep or sitting. Okay. Our antifungals, what is the main adverse effect?
Hepatotoxicity?
Hepatotoxicity. So, which is probably why it's not the drug of choice.
Could it possibly cause immunosuppression as well?
Antifungals? It might, and I just don't know. I don't think so. When I think of immunosuppression, I think of the cancer drugs. There's so many like steroids, and I don't know, but I can find out for you. Yes, dogs usually get Aspergillus. Cats get other things like crypto and something else. There's a predisposition for Aspergillus. What is it? German Shepherds. Always German Shepherds. But yes, German Shepherds or any dog with a really long snout. Dulcis cephalic, yes. Any more questions about antifungals or really? Okay. Figaro, 3-year-old, now-neutered cat. He is sneezing, he can pure nasal discharge, some weight loss and anorexia. He's having some vision issues, vision deficit. He's got this mass on his nose. They call it a Roman nose. So what are we thinking? Yes, it is actually cryptococcus. They can also cause eye issues that will ultimately lead to retinal detachment. So retinitis, uveitis, anterior uveitis, all these can lead to retinal detachment. Yes, this is cryptococcus. How would you diagnose definitively cryptococcus?
Biopsy?
You can do it right. Well, Yes, you can do a biopsy. A little hard, but you can.
Culture, histopath,
You can do histopath or your biopsy.
culture.
Let's do antigen tests. Just blood. You can do all the other things, but a little bit harder due to the location of this, right on your nose and that bony area. The thing with aspergillus is it's not infiltrating your bone. It's in there in your nasal epithelium, but it's not sitting right on your bone. So we would just need blood for these cats. So Cryptococcus is one of those multi-systemic funguses. We already know that it can affect the eyes, but there's a couple other places that it can affect. Do we know which systems? Other than respiratory, because this is a respiratory. Respiratory. Main one would be, it's in the eye, it's pretty close to your,
CNS?
right, yes, so CNS. Mostly behavior changes, some of them have some ataxia. Lymph nodes, yeah, seizures. And if that retinal detachment or retinal issues get bad enough, they will become blind. Just a whole nother problem. Bone we know because of where it is, its location. What other diseases might you want to consider?
The polyp?
Yeah. This is a weird one. If it's an outdoor cat, I think Negro is actually an outdoor cat, then you want to do your minimum outdoor cat database. So that would be FEV, FELV, and FIV. It's a snap test. You already took the blood to get the antigen test for Cryptococcus. Just send it in. FELVs transmitted by like contact, saliva. FIV is more of a biting. So the way I think of it is FIV, V is vicious, biting and scratching, and FELV is good multi-cat households, sharing bowls, saliva, touching. Just a fun way to differentiate those. How would you treat him?
Antifungal?
Antifungals. It's easy. Just make sure you check them after they finish their treatment because it is cytotoxic and captures and things and stuff like that. Fluconazole. With all fungal diseases, I don't know about 2 months, but with skin diseases as well, you always want to treat past the resolution of clinical signs. Just keep that in mind. Yeah. 1 month. Okay. Didn't know it was 1 month, but make sure you treat after that because it has potential to come back after you stop your treatment. And a lot of times, owners will stop their treatment and then it'll come back. And then they'll be back to the problem. So just make sure that they have enough to last that long. Okay, this is Bingo. 11-year-old male border collie. It's 11. Presented for swelling of the nose, which appears to be in bear. He has some epistaxis, which is apparently increasing with its size increasing. You also notice starter, which is which one?
Starter is snorting.
Snorting. So what are we thinking about Bingo? Definitely neoplasia. Do we know the most common? Which one? Adenocarcinoma is the most common one in the nose. There's a whole. You have a question? Okay. There's a whole bunch of other things that can cause nasal neoplasia, carcinoma. Okay, lymphoma usually only in cats. Mostly number 1 cancer in cats. Definitely lymphoma. But if it's a nose and it's a dog, it's definitely adenocarcinoma, unless it's TBT. But how would you diagnose Yes. If you see any 11-year-old with some suspicious mass, definitely do some radiographs. There's no point in me taking it off because it's going to die soon. So make sure you do the radiographs of the chest. Make sure there's no meds in there. We actually had a case here in the spring where they did the check and there were meds everywhere in the lungs. It came back. So make sure you check. You can also do a CT or MRI. Those are more specific, but we don't have those here. You can do a rhinoscopy if it is in a place where you can get a biopsy, like with aspergillus. Go for it. If not, the radiograph should point you in your right direction. But again, your biopsy is always your confirmatory for any mass-like substance. How would you treat this? Yes, radiation is good for nasal stuff because it's not always the best thing to just take that off. I have seen some, they take the nose off, it's like blowflies. It's not pretty, but you can do it. But radiation, you can do. Chemotherapy, especially if it's lymphoma, lymphosarcoma. There's a lot of these animals that live long and well with lymphoma. So if I have neoplasia on my face, near my eyes, what else might you see? Yeah. What would you say? This one did have it. The eyes will bulge, yeah. Depending on how much of the bone is affected, there will be some facial deformity. Turbinate destruction kind of goes along with the facial deformity. You'll see that on radiographs, like we did with the aspergillus. It's completely gone. You just radiolucency on where you're supposed to have your cartilage. And they'll be painful when you open. If you touch the face, they're obviously painful, but opening the mouth tends to be a little difficult. This is a bow. 3-year-old male moved lab. He has this hacking cough. He was boarded a couple weeks ago, so no other findings on physical.
Bordetella?
What'd you say?
Bordetella?
Yes, Bordetella, which is the bacteria for kennel cough. There are some other things in kennel cough. Your parainfluenza, your adenovirus, herpes real, not as much. Canine distemper definitely causes some respiratory. These are all cause respiratory, but your main ones are at your top. Your Bordetella, your influenza, and your adenovirus, which is a part of one of those vaccines we give. So do you treat this? Yeah. Are they inpatient or outpatient?
No.
Definitely outpatient. It's contagious. You do not want this spread around your hospital because then everybody will have that cough. So send them home. But what are you sending them home with?
Antibiotics.
Antitussives for sure.
Antibiotics.
Antibiotics, okay. So a lot of times you have to. If it's really bad, or even some of these respiratories, especially big cats, use your better judgment. If it's very bad and they're clinical and they're miserable, send them home with both. But most of the times, I think about 3 weeks, I think it can go away. No, we don't want this in the hospital unless it's severe. In that case, they need to be in isolation. Because if it's severe enough and you send them home, they can come back with pneumonia. So we don't want to send them home and then they come back with pneumonia.
That's more money for you.
Any questions? This is Blondie. She is a female spayed golden. She has exercise intolerance. There's this loud honking noise when she's breathing. There's dyspnea, stridor, which is honking, increased effort, but when she's calm, it's no problem. So, what are we thinking?
LARPAR?
Yes. What did you say?
LARPAR?
Yes, LARPAR. How do you diagnose this in any animal?
You have to.
Yes, you need to do a scope. This is see the picture of the scope. How would you treat it?
Surgery?
Yes. What if it's bilateral? Do you have both of them back?
No.
Why?
Aspiration.
Aspiration pneumonia. Exactly. Don't do that. Just an example. Hypothyroidism does predispose me to it. It's like a far stretch, but it's due to some type of neuropathy that leads to, or that will affect the nerve that innervates your larynx, which is the laryngeal, the current laryngeal nerve. Some other conditions you might see. We have megaesophagus, also the same type of thing where the nerves can be affected. I've never seen her ask about these, but definitely laryngeal, honking noise after exercise, tie back only one side because it leads to aspiration. These you want to use the keywords because they all present with this respiratory issue. What did you tell the client? Yes, definitely neuter it. What else?
Why uterus? Because you don't want to breathe it?
So if this dog only see the clinical signs of this after extreme exercise, maybe we want to limit that. So this is Dusty. Dusty is a 1-year-old male and 10 working. He's also got this honking cough thing that's worse after exercise and during excitement. But it's a European, it's one. He's got a murmur.
Tracheal collapse?
Okay, yes, tracheal collapse. Especially in these very small, honky dogs. Anything that has that honking thing, I immediately think of this. This is what it looks on radiographs. When you're taking radiographs, we're going to make sure that you get both inspiratory and expiratory, because they actually will look different depending on what phase of breathing you catch the radiograph in, and you could miss it. So make sure you get both.
So for that one, that is respiratory?
Yeah, it does. It looks like expiration, yeah. Yeah, this is expiratory. Mm-hmm. We should write that on there. We got some trachea. Definitely due to the laxity of the tracheal membrane, so those rings do make it harder to treat. Predisposition. Small, middle-aged, honky breeds, especially if they're overweight, because that definitely makes it worse. So when you have these patients, is there anything else I can help? They need to lose some weight. Yes.
Collapse trachea is also, is it similar to when they have reverse sneeze, the reverse sneeze thing?
Mm-hmm.
I have a friend, she's not sure.
Reverse sneeze or laryngeal. So with the reverse sneeze, you don't hear the honking. So they do like this kind of, it's an inward heave, but they don't usually honk. Mm-hmm. So they'll come in wheezing, and if you're walking down the hall and you can hear it struggling to breathe. Yeah. But as with the reverse sneeze, it's like a, yeah. It's similar, but you'll more so get the honking with collapsed trachea. Okay. What conditions are usually seen? I think of the heart. So a lot of the dogs that get the collapsing trachea also tend to have these heart problems. Mitral valve, definitely. COPD, Also, they can't breathe, and this trachea collapse thing is not helping them. So a lot of times you'll find yourself treating those diseases, working them up for something completely different when we came in from the honking thing. So make sure you check your, or listen to your heart carefully and your lungs as well, and not just when you see the radiographs, like, oh, God, that's definitely collapsed trachea, because it could be something else in addition to it. And then treatment options, definitely weight loss. If you have fat covering your trachea, it can cause some issues there. Reduces stress. A lot of times these dogs are stressed out, which is why you hear them honking down the hall in the vet clinic. Yes, so definitely make sure that they have a harness on, so you don't have that constant pressure on their necks. Bronchodilators to send home for temporary relief. But as far as bronchodilators, why wouldn't it work well for tracheal collapse?
The trachea solution.
Yes, the trachea is not your bronchi. The bronchi is down here and the trachea is up here. It's a structural problem, not an actual physiologic problem like your bronchi. But it makes the owners feel better. Steroids, can't use those long term. It'll cause immunosuppression, and it can break down your muscle. Cage rest, sure. How much rest can you give a Yorkie? If it's so bad where they actually cannot open the airway on inspiration or expiration, there are some surgical options. I'm sure Dr. Moon went over those with you, but it's not a common thing. It's expensive. It has a high failure rate. So most of the times when we have these patients, it's all supported, because the surgical procedures, honestly, I can't even remember what they're called, because it's just not common. But definitely supportive care for tracheal collapse. Any questions? Okay.
Okay, yeah, so we have like 60 more slides probably, but I'm gonna skip some stuff, and I'm only gonna read it. And if you have a question, you want to know. But I'm really tired, and I know y'all are too. Okay, so we're gonna talk about lower airway diseases. So it's really important to know the different types of dyspnea. She really harped on that, I remember. And I didn't even remember talking about this, but it's good to know. So when we're talking about obstructive ventilatory disease or dyspnea, think about I always think about my airways, like my trachea, rather, like my hard structures of my trachea. And there's actually something occluding that airway. So you're gonna have an upper and lower you can have an upper and a lower ventilatory dyspnea. So think about when I'm pretty sure on this test I breathed in and out to kind of think about things. So when you have an upper airway obstruction, when do you think the phase of respiration the dyspnea would be in? So like think about when you breathe in, where is your negative pressure? Inspiration. So anything in the upper airway preventing air from getting into the body, think about air breathing in, inspiration. And then lower airway, you're trying to get that air out. Think about where your negative pressure is, and that will be on expiration. And there's an issue in the lower airways, the lungs, bronchi. I tend to think of it more as like a bronchi, and there's just something in the way, and that air is not coming back out to be able to escape. And then restrictive dyspnea is something. I'm gonna let you answer. What is restrictive? No. That is, so when we talked about our obstructive in this one, we were talking about our hard structures, our trachea. So when I think about the restrictive, I'm thinking about my lungs, and they're restricted for some reason. Maybe there's edema, there's pleural effusion, and my lungs can't expand. So I'm taking really rapid, shallow breaths. So difficulty breathing because the lungs cannot expand properly. So I think if you differentiate those two different types of dyspnea into essentially tracheal and then lung that'll help you. That's how I kind of did it in my brain. So how will a patient with restrictive dyspnea breathe? Think about there's maybe pleural effusion around the lungs. It's going to be rapid and shallow because those lungs, you can't get a good, big, deep breath. So rapid and shallow. And like I said, the fact that the lungs can't expand properly. And there are a bunch of causes, like I was saying, pleural disease, just fluid or some other accumulation in the pleural cavity, allowing those lungs to be unable to not expand. A chest wall disease, like a tumor or growth, or even a fractured rib, where you can't, it's maybe painful to expand that chest wall, so you're still getting those rapid, shallow breaths. Diaphragmatic disease, we know the diaphragm controls the pressure in the chest, and maybe there's something going on with it, and you can't expand that chest again. And then diseases in the peritoneal cavity, we have abdominal fluid or abdominal organs, and we still, again, cannot expand that cavity. So restrictive, think about restricted lung and restricted space where we just can't inflate those lungs like we want to. And then peripheral nerve, so phrenic nerve, which of course innervates the diaphragm. So what type of dyspnea would you expect to see with a nasal tumor? So think about something in your nose. We talked about the air with the pathway down, so obstructive inspiratory and expiratory dyspnea. Because the tumor is fixed, there's nowhere for this air to go. It's having trouble getting in, it's in your inspiratory pathway, and it's also blocking the air when it comes out. What about a tumor in the lungs? So think, like when you're thinking about the dyspneas, I know this is like very broad, but if it's in the upper airway, kind of think inspiratory, lower airway, think expiratory. What type of pattern would you think we would see with pleural effusion? Do I? I don't know why this one says inspiratory, but I'm gonna fix it because that's not what I would have thought in my head. So y'all ignore that one. But it is the shallow breathing.
So
I don't know why it says that. I'm gonna look into that one because I don't know why it was an inspiratory. For pleural effusion, that doesn't make any sense. But then you can do the yeah. Pretend this says restricted. I don't know why it says inspiratory. That makes sense to me. But it does, I mean, the explanation is correct. Like the fluid in the chest does prevent the lungs from expanding fully, and it would be rapid shallow breathing. Sorry about that, guys. So tell me how you would differentiate a crackle from a wheeze. Yeah, so when I think of a great example of a wheeze is, I don't know if you guys ever heard a recurrent airway obstruction in a horse. That is a great example of a wheeze. And I'm going to try and play this video for you guys. That is a great example. If they ever have an REO horse over there, just go listen to its lungs and you'll never forget what a wheeze sounds like. And that, let me talk about that one first and then mention that one first. So wheezes are heard when air is moved through a narrow space. So in recurrent airway obstruction, there's it's essentially asthma in horses where that bronchiole and the bronchi are constricted and they're narrowed. So think of the air moving through a narrow space. And then crackles are an abrupt opening of the airways during inspiration. So that's going to be like a sticky, poppy sound. And I'm going to try and play this video. Oh, no, it's not that. It's this one. Have y'all learned about mm-hmm. It's essentially like constriction of the bronchi. I don't know if that's going to work as well as I wanted it It was very loud. Do y'all hear that at the end? You hear that? Do y'all hear the I know. This is what I used to listen to, like heart sounds and stuff, and I was like, oh, this will be perfect. How do I get my- Do y'all hear the whoosh? Man, okay, I'm sorry. Where did that go? I'm gonna send y'all, so I always use these videos right here, ThinkLab, I don't know, they're really good for murmurs and sounds, like arrhythmias and stuff. And somebody remind me, and I'm gonna send y'all the link and you can listen. Because they're really great to be able to differentiate, and then when you hear an actual case, you're like, oh my gosh, I know what that means. And they're good for murmurs too, hint hint, when y'all get your cardio and don't know what's going on. Still don't know what's going on. So I'm gonna skip this, but it's really, really important. And we made fun diagrams for y'all to be able to figure it out. So the diagram, just think about, this is your oxygen out here, your environment. This is your trachea right here. These are your alveoli where the gas exchange is occurring. So the oxygen is going to be in red, and your oxygenated blood is red, and it's coming through the capillary bed in the lung out to the vessel, getting exchanged into the CO2, which is your deoxygenated blood. And what we have done is we've taken each scenario of the different types of hypoxia and put them in a drawing form because they are really confusing. If it's still confusing, y'all let me know and I'll go over it with y'all. Like this first one is just reduced, essentially reduced oxygen in the air. So like when you're hiking or something in Colorado, wherever, there's going to be a decrease in oxygen going into your trachea and your lungs. So I have the O2 crossed out. You're going to have increased CO2, less oxygen. Does that make sense? And I'm going to let y'all go through those because that would take us like 40 minutes. We have VQ mismatch in there, diffusion impairment, AV shunt. But when I went through these last year, it helped it make a lot of sense. So I'm going to get to the cases. This is Ringo. He's a 10-year-old mixed breed dog, presented for lethargy, coughing of 3 weeks. During this time, Ringo's students have lost weight. He has a fever of 103.5, and pulmonary crackles and wheezes are also located. So here are radiographs. Have y'all had thoracic radiology yet? Okay. So what are these things right here?
Pulmonary artery.
American specimen. Alveolus. The artery demand.
Yeah.
There's this really special name for them. Aerobrachogram, yes. So in an alveolar pattern, I know, look, I still have problems with this one pattern, so don't. The rotation does stuff. So these guys right here are aerobrachograms, and that is when there is a opacity around the airways. So there's a problem in the lung itself, the lung parenchyma, and the airways are outlined, like you can see them better. And this is indicative of an alveolar pattern, and an alveolar pattern in the cranial ventral lung lobe is very specific for something. Do you know what that is? Pneumonia. Know that for the rest of your life because I just kind of met for a question about it like yesterday.
Could you repeat that?
Yeah, so an alveolar pattern, which you'll have your aerobrachograms right here, and you'll get more in your radiology rotation, so don't worry if you're not like super sure now. In the cranioventral lung lobes is indicative of pneumonia. because there is something in the actual parenchyma, and that's an alveolar pattern indicates. And up here in the dorsal, just for fun, the dorsal lung fields, there's an interstitial pattern. So pneumonia is what's going on in our case. And this is, again, alveolar pattern in the cranioventral area of the lungs is almost always pneumonia. What is the most common cause of primary pneumonia in the dog? And strep C. Remember these because she definitely asked about that. And then there are some secondary agents. Here's a fun way to remember that every person should serve Krabby Patties. And then distribution of the pneumonia can help you further classify it. So if you just have a focal area of an alveolar pattern, maybe a foreign body is in there, and we actually had a dog with a foreign body in its lungs in the clinic the other day. Dependent, like I talked about with the cranioventral alveolar pattern, will be pneumonia, maybe due to aspiration. Y'all know that's most common in the right middle lung lobe. So right middle lung lobe, alveolar pattern, aspiration pneumonia. And then caudodorsal, that's going to be your hematogenous spread from a septic condition, because that's where your blood vessels are coming into and most congregated at. So what is another way to diagnose pneumonia? Transtracheal wash with cytology and culture. Do y'all know the difference between a transtracheal wash and a BAL? Mm-hmm. So transtracheal wash, you're just putting that, you're putting the fluid into the trachea, putting it in there and sucking it right back out, and it'll just go like essentially to the thoracic inlet, and that's where mostly your bacteria are going to sit, and it'll be great for culture. And then your bronchial alveolar lavage is when you want to get a cytology sample more, because it's going to be a direct cytology sample from your parenchyma and your alveoli. But we don't want to do BAL in this patient because there's already fluid in that parenchyma. Don't put any more in there because that will make a problem worse. So what therapeutic options should we avoid in patients with pneumonia? Antitussives, because you want them to cough it out, essentially. Cough out the demons. That's what I always kind of talk about. And you only want to use, like Jasmine mentioned earlier, antitussives in a dry honking cough, and you kind of want to use it in a kennel cough because it is uncomfortable. So just remember that you want to cough out the demons and the junk.
Think of it like if it's something infectious and you have a little bit of hole in your coughing that can come up, you want that to get out. If you're like in an environment where it's cold and dry and you have like nothing really coming out, that's really, you need it then. But with the phlegm, you want that to out. Anything infectious that causes that thing. You don't give anything infectious, you gotta get out. Like you said, you gotta get it out.
Yeah.
Sorry, I'll take you back a little. You talked about the caudodorsal, caudoventral, and middle lung lobe. What did you say happens in the middle lung lobe?
The right middle lung lobe is your most common area for aspiration pneumonia because I don't know if y'all have ever seen a endoscopy. I always go back to learning endoscopy in a horse. The first lung lobe you're going to go to, actually, in your like pathway of your endoscopy, if you're traveling down your lung, is your right middle. So anytime you have an aspiration, that's going to be your first, what am I trying to think? First lung is right there, is your right middle. So that's why aspiration pneumonia occurs in that lung lobe. Branch, that was the word I was looking for. Oh, sorry, we can talk about this. Okay, corticosteroids are also contraindicated because we don't want to suppress that immune system even further. They're trying to fight off infection, don't want to suppress the thing that's trying to fight off the infection. And we talked about this earlier. How long would you want to continue antibiotics for in these patients? So 2 weeks past resolution of clinical signs. So in our fungal, 2 months. In our bacterial, 2 weeks. And this is typically 4 to 6 weeks total. Again, we said 2 months past resolution of clinical signs. So it's a fungus. Fungus are hardier, I guess. So they take longer to kill. So this is Annie. She's a 2-year-old female spayed red hound coon, presents for acute blindness, coughing, dyspnea, lethargy. She has a fever, hand ophthalmitis. She's in respiratory distress. Loud, harsh bronchiovascular sounds are heard on auscultation, essentially like coughs or wheezes and crackles. She has a history of living in a development where there has been recent construction. There are also ponds with decaying material nearby. She presented for another vet for lameness a few weeks prior and was treated with carprofen, but it did not help. And here is her nasty eye condition. Here are the thoracic radiographs. What kind of pattern is that?
Interstitial? Bronchial?
Yeah. There are like 3 sides? Okay, so fun radiology review real fast. So if you have all these little dots everywhere, beep, 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 little dots, miliary. And that's indicative of fungal. Yeah. And if you have nodules, big nodules, what is that? Nodular pattern, that's going to be your med check for metastasis. What are our differentials for this dog? Blasto, histoplasmosis, coccidiomycosis, crypto, aspergillus, all these fun fungal agents that could cause the multisystemic disease that we talked about, the lameness, the eye condition, and the lung abnormalities that we saw. And that's our miliary pattern. She might use the word miliary pattern, I'm not sure. But that's going to indicate a fungal disease of the lungs. Yes.
So the biliary and the nodular are types of.
What's the third one?
Just regular interstitial. I have to look at my notes.
So they get into miliary and nodular, the ones that make sense.
Mm-hmm.
And then there's this just interstitial guy. Go talk to Dr. Destiny. It's not, it doesn't look like either of those two.
It's more of a cloudiness.
Cloudy is not as bad as a little bit. But she does a great job. So not as good. At this point in time, I'm just that's me.
Maybe.
So, see what you think about it. Really, if all else fails, I use good energy. It doesn't look normal, and it's kind of funky. It's not. It's air bump brand. It's not the other one.
Tracks or donuts.
Donuts.
But
I would have.
miliary is like all the little dots are very specific for fungal, blasto, histo, all that stuff. And of course, you need a culture and cytology to determine which antigen. And y'all remember like broad-based flooding and all that fun stuff, Ohio River Valley, things like that. So treatment options are, of course, your azole drugs. Itraconazole is treatment of choice. Fluconazole, amphotericin B is nephrotoxic. And it actually is good in use in combination. And then ketoconazole. Why do we want to use ketoconazole in cats? Very hepatotoxic in cats. So this is Remy. She is a 12-year-old, he's a 12-year-old male neutered Springer Spaniel, presented for weight loss, lethargy, dyspnea. That has progressed over the last several months. He's still exhibiting an expiratory dyspnea. Temperature is 101.2. Here are thoracic radiographs. What do we see on these thoracic radiographs?
Leaves.
Leaves. What is the most common tumor in the lung of a dog? Yay. That was the same one in the nose. So respiratory tumor in a dog is going to be adenocarcinoma. Squamous cells possible, anaplastic carcinoma, and metastatic tumors, such as osteosarcomas and meningiosarcomas. So here we have some pulmonary edema. This is our interstitial pattern. Do we see how hazy this is? So I like to compare when I'm trying to look at thoracic radiograph, try and look at this black background back here, and it should look similar. But see how hazy this is, and it's kind of hard to differentiate everything. And that's our pulmonary edema. There are a few causes of pulmonary edema. Think of for decreased colloid pressure, colloid osmotic pressure. That's going to be the pressure that holds things into your vessels. So that happens when you have hypoalbuminemia. This can be due to a protein or protein losing enteropathy or nephropathy, where you're losing your albumin, a hepatic failure because albumin is made in the liver, decreased intake, low protein diet, or a vasculitis. And then increased hydrostatic pressure, that's going to be the pressure forcing your blood through the blood vessels, like not out, but through. This is kind of commonly seen with left-sided heart disease. Remember, left-sided heart disease is going to be lung, left lung. Right-sided heart disease is going to be in the abdomen, causing ascites. And just for information for your life, find a good heart cardiac picture of the heart, draw it for your exam, use it for your life, and then when you have to go back to cardio 1,000 times, so use that picture. Like, have one good solid picture with all the vessels and everything, have your lungs drawn out, so when you have to think about these things, like, okay, why does left-sided heart failure cause lung disease? That's because it's all backing up. So go ahead, find a good picture. I promise we'll save you a long run. Go down and go cardio a bunch of times. And this, sorry, I got distracted. So increased hydrostatic pressure due to cardiac disease, a fluid overload. You can actually give your patients too much fluid, and then it will end up leaking out of the vessels, or an obstruction of the pulmonary veins, which is opposite of left-sided heart failure. There's actually something in it. And then increased vascular permeability, which is when your vessels get leaky. And there are two types of pulmonary edema with the vascular permeability. Like we talked about, there are cardiogenic, left-sided heart failure, and there are non-cardiogenic. And the biggest one that they always talk about, especially on NABLE, is electrocution. Can cause a non-cardiogenic pulmonary edema. Gastric smoke inhalation, drugs, cisplatin, splat cats causes a fatal pulmonary edema in cats. So diagnosis of pulmonary edema, like we talked about, interstitial to alveolar pattern. I like to think of interstitial as like not as bad, and then when you get into alveolar, that's like really severe. It increases in opacity, so you can almost think of it as it increases in severity. ECG to rule out cardiogenic disease, a serum albumin to rule out decreased colloid oncotic pressure. So this is Tommy. He is a 4-year-old male castrated indoor outdoor cat, presents for tachypnea, tachycardia, and an expiratory wheeze. And y'all key in on these things that like say expiratory wheeze or inspiratory wheeze. Those are leading you to where you're localizing your lesion. Like, yeah, a lower airway or an upper airway problem. On physical exam, you hear wheezing, and Tommy has an expiratory dyspnea. So from here, what do y'all think this could be? Just from wheezing and an expiratory dyspnea. Yeah? Is that what y'all think? I can't really hear y'all. Yeah. So wheezing, we talked about with the constricted airway, feline asthma, like I talked about with the horse, that's same thing, recurrent airway obstruction is feline asthma. So that's where our wheeze comes in, that's where our expiratory wheeze comes in. Because there's something obstructing our lower airway, trachea, can't get the air out. And beyond heartworms is another differential for that. So here we have another fun lung pattern, sorry guys. But can y'all see all the little donuts here?
Yeah.
So that is an inflamed end on bronchus. That's an inflamed airway. So if you ever see a cat, pretty much with the with donuts, failing asthma until proven otherwise. So based on your radiographs, what do we think our diagnosis is? Asthma. What would our diagnostics include? Radiographs, which we did, we saw our donuts, our bronchial pattern, hyperinflated lungs. I didn't point that out, but you'll see how this is the line differentiating this lung lobe between this one. Look how big this is. But the donuts, you're golden if you see those. So in the flattened diagram, and collapse of the right middle lung lobe can also occur. Pathology will be infiltration of eosinophils, because you're going to see eosinophils with parasitic or asthma type diseases. You may see macrophages and neutrophils. Treatment options. My cat has asthma, so yay. Reduce stress, oxygen therapy, theophylline or albuterol, which are bronchodilators, and terbutaline so you can start with these if they're in acute respiratory distress, like in this cat is receiving this aerated one, and then terbutaline is actually an oral formulation with bronchodilates, and they can take that for the rest of their life. Prednisone, decrease inflammation, cyproheptadine, which is an antihistamine, inhaled steroids through inhaler. My cow is not having that, so she gets reduced stress pretty much. So, if Tommy would have had heartworms, what would we think about for heartworm treatment in cats specifically? What do we say? No melarsoline. Not use melarsoline in cats. So we know for dogs, we do our doxy, our pred, our ivermectins, and we do our melarsoline eventually. Cats cannot handle melarsoline. Yeah, steroids for cats. So reduce inflammation pretty much and supportive care for cats, and heartworm preventatives to prevent them from getting more infection. So we're just kind of trying to control the worms that they do have. What is the lifespan of heartworm in anyway? 5 to 7 years. Yeah. So here, we're trying to differentiate our pulmonary edema from our pleural effusion. So our pulmonary edema is our actual lung parenchyma. It's filled with fluid, or there's something backing up, but that is your lung parenchyma. When we think about our pleural effusion, that is the space around the lungs. So don't get those confused. This is just space around the lungs, can be filled with either a pure transudate, modified transudate, and exudate, Kyle's effusion, or blood. And then it's really important, she definitely is going to ask this, to know the makeup of each type of pleural effusion. And this is fluid in the pleural cavity. So we're just going to go through each one. Pure transudate, this is clear, and this is going to be versus your exudate. Your transudate is going to be a lot more clear, and it's low and low cellularity, low protein content. It's usually going to be clear or maybe slightly late yellow. This can be due to vascular volume overload. So if we gave those fluids, we can actually cause pleural effusion and pulmonary edema. Hypoalbuminemia due to our decreased oncotic pressure through the various reasons I mentioned earlier. Modified transudate, we're getting a little more cloudy, half and half. Protein is less than 5 but greater than 2, and cellularity is in between 1,000 and 5,000. And this can be due to heart failure, diaphragmatic hernia, neoplasia, pericardial effusion. And then exudative effusion, high and high, a thick yellow purulent discharge, or material, not discharge. And you see this syringe in this cat. If you see exudative effusion in a cat, it's going to be FIP until proven otherwise. And that's greater than 5 and greater than 5,000 in your celerity. And Kyle's effusion is a milky white to pink color. It's diagnosed by measuring triglycerides, and the triglycerides in the effusion will be 2 to 3 times higher than they are in the serum. And this is due to obstruction of the thoracic duct, which can be caused by trauma, heart enlargement, or neoplasia. And so pyothorax, what is the most common cause of pyothorax? That. Most common are these top two, and Pasteurella and E. coli. And what is pyothorax?
Busting the thorax.
Yeah, so make sure y'all remember like hydro, pyo, all that stuff, because she'll probably mention that too. So if we mention something that said most common, definitely make sure I'm at this. I hope that this helped you guys out. If y'all, of course, have any questions, let us know. Thanks for sticking around. I know that was a long one.
Thank you.
You're welcome. Josh, I'm gonna shut this down. Do it.
Let's go get
He did.